afternoon, everyone, and welcome to the latest webinar of our series on Innovation and Behavioral and Implementation Science Healthcare by the Center for Behavioral Implementation Science Interventions, or BISI. My name is Giuseppe Alessandro Veltri, and I will be your host and moderator for today's session. Today's webinar is titled Rapid Evaluation and Implementation in Public Health, from Evidence to Policy and Practice. This is a topic that I think is especially timely in a public health landscape that is changing faster than ever. The ability to generate actionable evidence quickly without sacrificing any rigor is becoming essentially for informed decision-making. We will be exploring how rapid evaluation approaches can help us scope the right questions and make the most of existing data, and navigate the inevitable trade-offs that come when we work under real-world constraints. I'm delighted to be joined by two distinguished scholars. Our guest speaker is Professor Ioannis Bakolis from King's College London. Ioannis is a professor of public mental health and statistics and the founding deputy director of the Center for Mental Health Policy and Evaluation at King's. His multidisciplinary research program has advanced our understanding on how climate, environmental, and social determinants shape mental and physical health, and it has informed public health policy and practice globally. A leading expert in the design, evaluation, and scale-up of population-level interventions, Professor Bakolis has secured over £30 million in competitive research funding and authored more than 170 peer-reviewed publications. Joining him, we have Professor Sevdalis, who is the academic director of BISI, familiar face for those who follow us. He also serves as co-editor-in-chief for the journal Frontiers in Health Service. Professor Sevdalis held before a position as Professor of Implementation Science and Patient Safety at the King's College London, and he has directed the Center for Implementation Science, also at King's. Before we begin, just a few housekeeping points. The webinar will run for about an hour. We like to keep these sessions as interactive as possible, so please do use the Q&A function in Zoom to submit your questions anytime during the webinar. I will collect these questions, and then at the end of the webinar, we will have some time to answer a few of them. The session will be recorded, and it will be made available afterwards. So without further ado, I want to now introduce you with Professor Ioannis. Good afternoon, Professor Ioannis. Welcome.
Good afternoon. Thank you very much. Thank you for this wonderful intro, Giuseppe. I'm delighted to be here. And today, as you said, we're going to discuss about rapid evaluation rapid evaluation implementation in public health. And I'm delighted to be here. I have some slides I would like to share to introduce everybody on to give a little bit of definitions and introduction of the topic. So I'll start with a 10 minutes presentation on this. So, as I said, thank you for the amazing introduction. I'm delighted to be here to discuss about a topic that I'm really passionate about. So today we're going to discuss about rapid evaluation, and rapid evaluation is an approach which, as you mentioned, Giuseppe, is all about generating timely decision-making relevant evidence about the implementation, effectiveness, and the impacts of policy interventions and health services research as well. And we use rapid evaluations, particularly in contexts where clinical trials are not feasible, but also if we want to make rapid real-world decisions. The key message that I would like to convey, if you have to keep one word from today's presentation, is that how we can ensure doing rapid evaluation, but also don't compromise the rigorousness of our results as well. And we know that they prioritize speed and responsiveness, and we're going to we're going to say how we can prioritize speed and responsiveness, but as well as rigorousness within these rapid evaluations. And we'll discuss different methodological challenges being involved, how we can incorporate hybrid implementation approaches where they can help us generate actionable evidence. And as you mentioned, I think, I don't know, like every year feels like the world is in a state of emergency. This is how it feels definitely from the start of this year. And this is not a difference between when we're discussing about public health. We face emerging infectious diseases. We faced that like 5 years ago, had a global pandemic. Climate change is around the corner, or even past the corner, a long time ago. And we have widening health inequalities, as well as we have a prevalence of increasing mental health conditions as well. So what we need is like how we can generate rapid evidence in public health. And the idea is that, and something that we learned from the COVID pandemic, is that we can use rapid evaluations to complement traditional kind of studies. So just to give an example from our line of research, one of the studies that we did during the COVID pandemic is we would like to understand what will be the impact of mental health, the impact of the lockdown and COVID-19 kind of lockdown measures in mental health services. And we needed to provide rapid evidence. From that rapid evidence, we understood how that people with severe mental illness, for example, they will be had more increased mortality compared to the average population. And then that rapid evidence helped to generate, helped to prioritize people with severe mental illness within the vaccination rollout. But then traditional randomized controlled trials came into place. And within this, we had like kind of more kind of clinical trial effectiveness studies regarding to that. And these are kind of adaptable designs that we can have within any type of kind of new kind of emerging policy priority that we might have. For example, I mean, like if we want to look at climate change adaptation policies, rapid evaluations could be the key to provide us actionable evidence and fast-pacing kind in a very fast-pacing landscape as well. And it's not only public health, but rapid evaluations can be very helpful in relation to healthcare. This is a very visual graph from a paper that published some years ago, which shows the gap. What is the gap between academic evidence, the generation of academic evidence, and how long does it take to actually become routine clinical healthcare and practice? And this gap was estimated back then to be 17 years. Of course, depending on how much priorities we have and how much rapidly we would like to do things. So again, moving back of when we are facing kind of an emergency, like for example the COVID pandemic or now climate change, we want definitely to reduce this gap. And we one of the positive aspects is like we managed to reduce this gap in terms of different studies that we run within this. However, still, we need to understand and how to make more rapid and more translational the evidence that we generate. And there is kind of two ways of evidence generations to policy and vice versa. And there are two complementary modes. This graph is taken by a paper that was published by Olivier in 2020. And these different types of evidence generation around this could be that we have the traditional path where we have interventional development. So we develop an intervention. We have some feasibility and pilot trials run within that. Before we have a definite randomized trial, then we synthesize the evidence. Maybe we run like different types of trials within different settings, and then we'll generate policy action. And that's one way of policy action and from evidence generation. However, it could be the other way around, that there is already a policy in place. So there is the the political climate to actually a policy to be timely, and policymakers can be vested on that policy, so they want to roll it out without sufficient evidence around this, or with no evidence around it. We have policy action, and then we are in the position when we want to evaluate the impact of that policy, and we can do that with a natural experimental evaluation, which we'll talk a little in a bit, and we create some evidence synthesis. And then within this, what we're suggesting, like how we can couple these ideas with some kind of novel new designs, where we're not only interested in the effectiveness of a policy, of a population health intervention or a health kind of care intervention, but also we are interested in the implementation of that study. And the person to help us to do all this is Nicolas Cage. And Nicolas Cage, apart from having this very awesome haircut in Conair, he is responsible of one of the most famous graphs in statistics, where has to do around what happens with correlation in specific studies. And so you can see in the graph, this is a graph that he is very famous of. I don't think that Nicolas Cage knows that. Is that we can see in the graph that on the one axis, on the y-axis, we have the number of drawings that happens within the United States between 1999 and 2009, and on the x-axis of the graph, we can see how many times during that year Nicolas Cage appeared in a movie. And like we can assume that probably, that there is a causal effect on this, but to be honest, this is not very plausible, because Nicolas Cage, for example, is an Oscar, has been Oscar nominated 2 times, and he has won once. So the idea is that probably this is not related to the drawings around this. So we can build a lot of correlations around the evidence of policies and particular impact that they might have, both on the effectiveness, on clinical outcomes, but both on the implementations. But we really need to be careful about what is the causal assumptions that we do around this. And just not only to discuss about Nicolas Cage, to discuss about something that we did with my group some years ago that received a lot of media attention around this, is that when we linked urban air pollution, we provided a link between urban air pollution as measured with very small particulate matter and gases that comes from vehicles. We link it to with an association with increased hospitalizations within the area that we're operating, with people with pre-existing mental disorders. And this received a lot of media attention. This is an article from the Guardian newspaper, a UK newspaper. It has a wider readership, wider international readership. And within this was a classic observational study. Because we're dealing with issues like air pollution, this is a study that we cannot conduct a clinical trial. We cannot randomize people receiving high levels of air pollution and people not receiving high levels of pollution. This will be unethical. So we sat down with the environmental editor. We explain our approach. We explore how we measure pollution, how we measure mental health, how we take into account other types of variables that they can play within the association between air pollution and mental health. We use some novel approaches, for example, such as E-value, to take into account some unobserved kind of factors that could play into the association. And then the editor came at the end of the interview, after 1 hour, and asked us, can we really say that air pollution is causing mental health? And the answer to that is no. We cannot do that, because by design, we don't have this available information. And there is like 2 different ways that we're trying to tap into within this. So we can do that, obviously, with experimental type of studies. So we know that randomized controlled trials can produce results with high internal validity. However, there are 2 reasons that we cannot do that. The one reason is that it's not ethical. So, for example, in the example of Nicolas Cage, we can randomize people watching Nicolas Cage movies and not watching Nicolas Cage movies and seeing their behavior afterwards. However, as I said in the example of the air pollution, we cannot do that. And interventions can differ from those in routine practice. So RCTs could work very well in a well-controlled setting, but they limit the generalizability of the results, so they limit their external validity. And on the other aspect, we have observational studies that they can produce good generalizability. So we, especially nowadays with this kind of big data explosion and with all the information around digital technologies, we have a lot of information and we can have population level studies around that. However, the internal validity of observational studies is compromised because the assignment of the intervention, the randomization, is always being influenced by certain unobserved characteristics that also could affect our outcomes. And the kind of the golden compromise that we're taking into research is to use natural experiments. So we use studies that happens within the realm, within the context, within our societal context. For example, I mean, one natural experiment that's very famous and that runs globally is the smoke-free legislation that happens around globally, and this happens in the last kind of two to three decades that happens that. And within that, we can have like information from administrative records, from electronic mental health records, from different administrative data, and then we can run different types of designs, which they can inform us about the evaluation of a specific policy without have to rely to conduct a 3-year, 5-year clinical trial. It seems, like very simple and very easy to conduct. It's very difficult in practice to ensure that results can be valid and they can be comparable to a clinical trial. But there's been an explosion of designs, within the context of natural experiments, such as interrupted time series designs, propensity score matching, differences approach, and regression discontinuity design. So instrumental variables, and this is designs that have been used from policy evaluation to genetics, to epidemiology, to public health. And these are designs that they assure that there is a compromise between rapidness and rigor, and ensure that the rigorousness of our approach is embedded within our evaluations. And also what is being very much pushed towards the years, and this is kind of a great initiative, is to think our observational evidence and observational studies in terms of target trial emulations, which is a powerful approach that allows us to strengthen causal inference, not only rapid evaluation, but in any type of observational data. And the idea is quite simple in the making, is quite difficult in delivery, is to explicitly design an observational study as we were conducting a hypothesized randomized trial. So we clearly define our inclusion criteria and exclusion criteria, eligibility criteria of the population, our treatment strategies, our follow-up, and our outcomes in advance. And then we try to run the study as we run standard operating procedures, for example, for a clinical trial. And we can use their observational evidence or administrative data to emulate the trial as closely as possible. And this is very valuable in the context of rapid evaluation because, as I said, the key message and the key word that I want you to take from today is not only rapidness and responsiveness, but basically is rigor on this. And this is a seminar which is in the Behavioural and Implementation Interventions Center. So we cannot think rapid responsiveness and translation without thinking that implementation should take a place within this. So we're not only interested in how we know that the intervention is effective, we need to ensure how the intervention is delivered appropriately. And also we need to ensure and to incorporate how an intervention is delivered over the long term. And that's quite key. And the idea of dealing with this is that what we call within research, like what we call a hybrid design. And the hybrid designs are fitting within where effectiveness research and implementation research lies. And between that space that we're describing there, we try to improve our processes and our outcomes. And in the last in the last 15 years, there's been different characterization of how we discuss about hybrid designs, and we move now. Although the whole idea between hybrid design started from clinical trials, we try to move now to talk about hybrid studies. And one I will try to bring forward today is that we can incorporate all these hybrid designs when we are not only designing a clinical trial, but we can move and do the same notion when we're designing, for example, a policy, or when we're designing a healthcare intervention as well. And the hybrid designs could run from different types of hybridity, let's put it in this way. And this depends on how much evidence we have in relation to effectiveness and in relation to implementation of a study. So if we have, for example, we don't have a lot of evidence of effectiveness of a policy, we need to test the policy effects and then observe data on implementation. If we have some evidence around the policy, we can test the policy effect, but equally test the implementation of the policy. And also we can, if we have like enough evidence for a policy that works in different contexts, then we're focusing on implementation strategies. It's a way to how we can adapt hybrid designs within this context. And that's quite key to make rapid translational gains in real world kind of scenarios. And within this idea, which always encompasses not only quantitative data, like electronic and administrative data, but it involves a lot of data that comes, for example, from qualitative interviews or from different type of research, which doesn't involve large administrative records, is that how we can engage with and map the different stakeholders that we have within a policy, within a population health intervention, within a healthcare intervention, and how we engage all the implementers, the funders, the policymakers, also the research academics that run in the evaluation, as well as the patients and service users, which are very key to our knowledge on this. And I'll stop up now. Just I want to flag that if you find interesting a little bit this kind of taster of what rapid evaluation implementation could sound in public health policy, I would like to say that we have a designated one-day workshop tailored on 10th of March of 2026, which will cover most of the topics that we discussed today. We'll go to a deep dive of what is rapid evaluation, how we can incorporate quasi-experimental designs within this, and how we can establish causal inference frameworks that can help us with these designs with practical hands-on example, and also move to hybrid designs and how we can inform policy with these types of designs. So if you're interested on the topic, please register. We'll be very happy to discuss in more detail about this very interesting aspect. Thank you very much.
Thank you, Ioannis. I will now ask Nick to comment or respond to Ioannis' intervention. Please, Nick, the floor is yours.
Thank you very much, Giuseppe. Thank you, Ioannis. That was absolutely fantastic. You probably, both of you know me well enough. This is a topic I feel very strongly and I'm very passionate about rapid evaluation. So it's absolutely a delight to be here this afternoon for us, morning for you, Ioannis, talking about this. And obviously, thank you to the several dozens of participants that are joining us today. So there's a couple of thoughts, and I've been jotting down things, Ioannis, as you're presenting. And every time you present on this topic, I sort of get more ideas. One thing is what I'm trying to do is a couple of comments to sort of kickstart perhaps our conversation over the next sort of 25 minutes or so. One point is a point of reinforcement, and another point is perhaps a challenge to not to us, but to everybody in the webinar, in terms of how we think about rapid evaluation, how we conceptualize rapid evaluation ahead. So the point of reinforcement is the latter part of your presentation, Ioannis, the fact that you shift the attention from the effectiveness, the traditionally conceived effectiveness, clinical effectiveness, or population health or public health effectiveness of a program, a service, or an intervention, to the implementation effectiveness, because we can use the very same language. It hasn't quite penetrated yet. It's been around. We're talking about lag in healthcare. You look at the hybrid studies, hybrid trials initially, now hybrid studies terminology has been around for just over 10 years, and yet the uptake has been relatively slow in some ways. And I think it's a field that's growing to all of our colleagues in this room. I think the very concept here is that you can actually trial an implementation strategy. So how you're going to implement a program, whether you're going to put your effort and your funding into leadership, into doing videos and podcasts, into doing campaigning, into doing information leaflets and sharing, or education, or facilitation of some sort with a lot of troubleshooting on a regular basis. We don't have ready-made recipes for this. And I think it's something that we need to reinforce. We're looking at interventions that improve health or improve public health outcomes. In the same way, we're looking at interventions that support the dissemination, successful dissemination and engagement with those, because essentially any intervention or any public health program will ever be as good as the uptake and the engagement that it will have. And that includes, and that's important, I think, for us based in Singapore, includes things that are embedded and enshrined in law. Because making something a sort of legal requirement, by all means, is a fantastic implementation lever that some policymakers at the highest level of government can pull. But further to this, we still see that the laws are followed with different level of conviction, if you like, and different level of implementation success, and therefore true behavior change. Smoking ban was a great example where you can ban it, but that's not this is one major lever, but you also want people to truly refrain from smoking because they believe it's truly not very good for them, and replace it with a healthy habit. So I think the concept here is that we can pull multiple levers, and there's a whole science of studying those levers. We don't have them ready-made in the same way as we don't necessarily have ready-made population or clinical sort of health interventions. So that's something to, again, reinforce as one of your learning points for your presentation. This is something that needs a lot of thought. In some settings, we don't talk about implementation, we talk about operational aspects of a policy. How is it going to get operationalized? In other settings, we talk about delivery mechanisms for a policy. No matter what you call it, there's the whole sort of field of evaluation that's being developed to sort of support it. So that's a sort of my point of reinforcement. And then my point of challenge, to all of us, is that we often start, and that's probably because we're all scientists and we're all trained in experimental methods in some way or other. We start thinking of rapid evaluation, or we position or we angle, I think, rapid evaluation in comparison to a randomized trial, it is the gold standard for establishing an internally valid causal relationship between what happened and the outcome, where we intervened and the outcome of that intervention. But I would challenge us all, and that might be food for thought, and I'd love to see the Q&A lighting up on this. The other comparator, this is a very valid comparator, but we've been there for several years now, so there's a lot written about this. The other comparator is no evaluation data whatsoever. Because the reality is, in my experience, for at least, there's so many policies, services, and interventions that get launched, they're funded, they might be sustained over time. And when you look at, or when you ask the question, did this actually work, or what did it improve over a space of 2 years, 2 months, 3 years, or whatever? The answer is we haven't quite measured it, or we don't really know how to measure it. And we were in a sort of rush to get something done. The funding was there. Our heart was in the right place because we thought we need to be doing something about the problem. But evaluation data is simply totally lacking. And I think we've observed in a lot of cases a gap between what scientists might be able to advise, which might be at the level of a randomized trial. Policymakers going, but that's not appropriate. It's not possible. It's not feasible. It's not timely. But then the alternative shouldn't, in my view, be we don't do any evaluation whatsoever. I think rapid evaluation fills a very important gap, not only when a trial is not appropriate, but also when evaluation data are needed. In my opinion, any major policy needs some sort of evaluation data, because otherwise we're flying blind. and we can never really get to the bottom half of your very nice diagram that would suggest that policy implementation can generate data, generate questions and evidence, which is very, very relevant to what happens with the longevity of that policy, how that policy might be better implemented in the future, and whether it should stop being implemented because it's not really achieving its goals. So that's a challenge to what we compare rapid evaluation to, in addition to thinking about randomized trials. So I'll stop here and pass the mic back to Giuseppe to guide us through the rest of the session.
Well, thank you, Nick. Ioannis, do you want to reply to Nick's comments, or I can just ask
I'll
also?
try to pick up one of the things. Thank you very much. That's wonderful points, Nick. I think there are two things there. So I think one thing I'll speak a little bit about, like running clinical trials within the implementation kind of context. So I think people who are trying to run now, like the run implementation trial, they know how difficult thing is to actually test implementation strategies within a clinical trial. And the reason is that I'm not going to go to the methodological problems we might have from running the trials and the operating procedures around this, because we need probably 4 or 5 webinars to discuss about this. But there is a key aspect of that, because implementation trials and implementation effectiveness as a knowledge as a kind of a topic is quite new. It's really difficult because to set up the studies, because there is no a lot of prior evidence around, let's say, implementation outcomes, implementation aspects, how do you develop that, around other aspects, even about, for example, administrative data that you can rely on, or data that you need to collect on, or scales that you need to collect the data on your strategies. And this is a very fast-paced and moving kind of environment that we have at the moment. And it's quite challenging. It's really interesting. It's changing things. It is the way forward with intervention that we know that it works. But designing and running an implementation trial requires a lot of effort. And the other issues, like people who are looking at this, they're not familiarized with a lot of the terminology as well. So there is one aspect. There is a lot of challenges that we face within the implementation studies. The other aspect that you mentioned is about the policy kind of readiness, and it's absolutely true. Like a lot of policies that they're happening at the moment globally, and this has happened historically. They're not always about evidence. It's not like you have 20 years worth of evidence that you want to pull into a policy. You come into that something is happening and you need to respond to that. But I think the key message here is that we shouldn't think rapid evaluation instead of a clinical trial. I think that's what I was trying to kind of communicate within the COVID example that I give at the early beginning around mental health services. So within this, we can think rapid evaluation, something that can provide us rapid evidence around a policy or an intervention, and then we can build up on that of how we can create and expand the evidence based within a clinical trial. So it can work as a predecessor of a clinical trial. But if the clinical trial is not feasible, we need to make sure that all this kind of rapid evaluation or this quasi-experimental design, we have the data infrastructure, both in terms of evaluation, but both in terms of implementation, because implementation data is something that we're lacking a lot in how we routinely collect them, in order to get actionable insights within a policy and have translational evidence that could be helpful for policymakers, for the public, for all the different stakeholders.
Well, thank you, Ioannis. I see that already questions are queuing in our QA. That's a very good sign out of the very large number of participants that join us this afternoon. So I'll also ask you a questions following up what you just presented to us and connects to what was just discussed between the two of you. So how do policymakers interpret and use findings from rapid evaluation compared to longer or traditional studies? Because they are ultimately the person you need to convince, to adopt this. What is your experience in this case?
Coming back to what I said, I think that within definitely when we're discussing with policymakers or we're discussing with the media, we like always bring it forward to clinical trial or bring in something that it's kind of historically be the gold standard around this. It's always helpful on generating evidence. However, there's something that always plays into this is how much vested interest and how much is the political context around this. So, for example, when we did a lot of work around, let's say, environmental stressors such as air pollution in relation to mental health and physical health as well, and the link between the two. In a city like London, I mean, like there is a big drive for environmental policies for reducing air pollution, and this is pushed by the mayor of London, for example. And so there is a policy readiness around this. So very key figures within the policy context of this are very vetted to these policies. So it's even if though there is a lot of observational studies that we don't have a clinical trial around this, there is enough evidence to convince that we can move forward with some of these environmental policies as well. Obviously, it doesn't mean that we need to always conduct a clinical trial. So that's one way to look at it. However, there is a lot of pragmatic studies that we do, especially with population health or healthcare interventions that happen within health services as well, that we start rolling out an idea, we start rolling out something that seems that it makes sense. For example, like integrating, let's say, physical and mental health care and how we are evaluating that system within a context of a psychiatric unit. But within that, we need to do something rapid, something to monitor and evaluate. And this could happen very iteratively. And it seems again that even when you have data on monitoring and evaluation, this could help as well action as we go until the time that we have evidence for a clinical trial. So I come back maybe to the same point that in order to have actionable evidence, we need not only methodological robustness that we can ensure from a clinical trial, we need contextual relevance. So if we have contextual relevance, that means that our evidence that we're providing could be actionable by policies, and also it's like how we triangulate for multiplier resources. And I think that's very helpful for policymakers, especially in the triangulation. So if you bring evidence that they're not coming only from very kind of rapid evaluation, preliminary studies, not only from clinical trials, but if you bring everything together, which involves obviously as well qualitative work and interviews with stakeholders. So that's the best way to approach that.
Thank you, Ioannis. Nick, do you want to add anything?
I can add a small point again. It's trying to just picking a word that Ioannis is using, and I think to me that word's absolutely important in the interactions that I've had over the years with policymakers, and that's the word actionable. So, and I remember some of the audience might have attended this. We had this sort of wonderful lecture in December that was given by the dean of our medical school, Professor Chong Yap-seng, and there was a panel following that lecture where we've had the pleasure to be a member of, and we had senior policymakers at the ministerial level, on the panel, and funders and so on. And the similar question came up, and they're very interesting to me, and as we remember this to this day. The comment that we had aired at that panel was, there is no point, you might have lots and lots of evidence, and the evidence might be of good quality, but then the policymaker looking at it from the perspective of, and what can I do about this? Because if the answer is not very much, the evidence remains an interesting story and something to know about and, be intellectually curious about and so on. But it doesn't lead to a policy impact. It doesn't lead to a policy action, because at any one point, there's potentially lots of things where a government, a ministry, a directorate or a health service sort of lead or director might decide that, we need to be doing something about, but they don't. I think the interesting thing for me was that, which of course sounds pretty much straightforward if that's what you do for a living. You're looking at where are the problems that I need to address, and then you look for the solution. Then the evidence appears as, and here is a solution that's got a good chance of getting you to the right outcome. You don't start from the point of, oh, that's interesting evidence, and therefore we need to start creating the pathways to implement that evidence. So the evidence might be brilliant, but if there is no policy lever to get that evidence into, a consumer, a patient, a population, a resident, the policymakers go, there's not very much we can do about this. And it's interesting where you compare, we talk about natural experiments, Ioannis, there's natural experiments happening at national level. I'm picking up my very few social media sort of feeds, all these comparisons now when Australia, a few months back, introduced a social media ban for children. Lots of countries, there's a lot of editorials, commentaries, papers, analysis, policy analysis, and prospective policy briefs written about how do you go about implementing the same. They're all watching. This is a big case study, right? It's a big, it's a big experiment, except we have no control unless you're a country that hasn't done it, and then you're comparing yourself to Australia. So this is a good example where the policymakers are considering. They took the plunge and they thought they could do something about a problem that we seem to believe we have. And here is the intervention, the ban, to reduce usage. Clearly, that's not the same decision-making process that other policymakers have reached in other countries where potentially the exposure to social media is the same. And which is interesting because, again, you can debate the evidence. There's a lot of evidence to what social media does and does not cause or is not associated with. But the interesting thing is that the trigger for the policy seems to me, the perception that, and this is within our remit to do something about. So the actionable part that Ioannis is talking about, I think is it needs to be put in boldface. That's really important.
Thank you, Nick. I think it's now time to take some questions from the audience. So I selected a few. I think I'll start with something that is fairly practical. Someone asked, how long do these rapid evaluations take? Considering that sometimes accessing to administrative data takes long, and there is also a scarcity of data, as mentioned from both of you, about implementation data. So normally, what rapid really means in real life, in your experience, what is the kind of cycle that you can, sort of give us an idea of what rapid means? And then maybe I'll pick another one. I think, let me see. Someone else asked, what are your preferred methods of documenting and describing the implementation strategies to enable hybrid studies? So they put, for example, the implementation logic model, or what else? So fairly, I would say, targeted questions. So please, Ioannis, the floor is yours.
Thank you very much. Thank you for the wonderful questions. I'll start first with how much is, what we define as rapid and how much is rapid. I think there's a fluidity of definitions within this, and this depends as well on the emergency that we are facing. So I think Nick gave a very nice, very timely point around social media in young people, which is a kind of a very topical issue that involves a lot of governmental, that concerns a lot of governments around the world. So, for example, when we give some examples around this to understand what we mean by rapid. So when so one of the studies that we did, we wanted to look at the effects of the smoke-free legislation on pregnancy outcomes. And we looked at with using hospital episode statistics data within the UK. So it was a population level study of pregnancies. We had, and it took us, it's true that we say that we use a quasi-experimental design to do that, but we say that this is rapid, but this is a study that took us probably a year to 2 years to actually bring it, analyze it, bring it into place, publish it and submit it as well, submit it and publish it as well. So like that timescales could be 2 years. Then COVID came, and within COVID, what we found is that because we were in a state of emergency, a lot of the data kind of regulations or data kind of sharing or data infrastructure or people that they were the data holders, because it was in a state of emergency, they relaxed a little bit the sharing of the data infrastructures around this, which obviously now we have again policies in place because we're not in the state of emergency, but this created created a context and a situation where we can have access to the data very quickly, that everybody had an interest to actually provide us that data quickly. Everybody was looking at different COVID policies, what does this mean for health, for mental health. So this helped a lot. And, a study that took us 2 years, it took us 3 months during COVID, doing probably the same thing. So it's, we can divide rapid around what is the problem that we are facing, then actually the other way around, that rapid needs to be, like a 3-month study or a 6-month study or a 2-year study. It could be any of those things. However, what we need to think is like what ensures us to make this kind of rapid, responsive, rigorous evaluation within the context that we're facing. Because in the smoke-free legislation, we could, wait. We could do something within a year and talk to policymakers. Within COVID, in a year, this is not what you will do. With climate change adaptation policies after a climate disaster, you want to be responsive. You don't want to wait 2 years to actually present evidence of how you tackle and react to that. I think that was part in the first part of the question. Would it be possible to repeat the second one? It was about implementation strategies.
Yes.
To be sure.
And the second one was, what are your preferred methods of documenting and describing the implementation strategies to enable hybrid studies?
I think I'll give an example. We're running a digital mental health intervention with the Brazilian students at the moment, where we are testing different implementation strategies, and it's really interesting. So within this study, the implementation strategies that we are using is more like kind of empirical ways that work in the past. So within the context of digital mental health intervention for low-income students in Brazil. And within this, we developed the different strategies as, delivering different interventions in different jumps of a trial within that, and we are collecting implementation outcomes of that. And this is the definition of a hybrid study, because this is a study where we have enough evidence about digital mental health interventions, but what we're really interested in is how we can ensure that how we ensure that implementation of how much ensure that the intervention this digital mental health intervention that we have, how we can ensure that is reaching and adopted by the different students. So how we're documenting that in a way, and probably Nick has more experience in this, is that we will roll out kind of different ways that we think of what it works within this context and what worked from previous evidence. And then we try to embed it within the design and try to measure it and evaluate it as we go from the process.
Well, thank you, Ioannis. I think probably we have time for one more question, and so I've selected this one, which concerns program evaluation. So the person here is asking that how should we plan and budget for the evaluation component of an intervention in a way that will convince policymakers to commit to program evaluation with enough rigor, and also to troubleshoot for early challenges in terms of equity oversights at the early phase of the pilot. So fairly elaborate question.
So how we can form a budget on this? I think the idea behind using administrative records within rapid evaluation is the trade-off provide actionable evidence and like the cost effectiveness that this has compared to a clinical trial is quite substantial. So clinical trials is a quite expensive way to run things. So if you can do the same study by suggesting that you can use electronic routinely collected data, that could be budgeted in a far more probably 1/5 or 1/4 of what you do. However, it takes time, takes effort, takes stuff to do that. We need. Some people think that it is like kind of we go there in 1 month, 2 months, and we can have actionable results. It's not that the case. You need to have a kind of a funding team around. You need to fund your team around this, which could be the data extraction managers, the people that are doing the analysis, all the workshops that you have within this. So it is a cheaper way to look at this, but it's not like something that we consider quite considerable cheaper. So I think within the budget we need to. This is one of the concerns that we think about the policymakers. I think policymakers, what we want to look is like how much does this cost and how long will it take to actually have evidence around this. So there should be a trade-off between that. If you need something timely, you go with administrative records, and you want something cheaply, yes, maybe then a rapid evaluation, if you have all the data landscape around you, that's a good way to do that. However, a lot of things that we are pushing over that they need to be trialed, because I don't want to convey the message that trials are not, useful. This is complete opposite. But if you really need to do a trial around this and provide like this kind of gold standard, robust evidence for evidence that work, then you need to make a good case of why you need 3 to 5 years to run a clinical trial, why it costs X number of millions to do that, why it needs to be at different sites in different countries. So it's a trade-off between the two of what you're budgeting, but it all comes to the rationale and how much convinced you are that this thing will be funded by the policymaker.
Thank you, Ioannis. Nick, would you like to add any other comments, please?
Yeah, I can add. I mean, I'm totally in agreement with Ioannis, and the additional sort of, I would sort of reinforce a consideration that he's sort of alluding to. It's the scope of the project and the scope of the investment. I mean, if you think about, there's no one single answer to how much budget would you allocate to doing an evaluation. I mean, the way I would approach it is that and it sounds like a bit hardcore, but I have said that before, so feel free to quote me. I don't think any major or medium range to major investment in a population health or a new health service should be done with no evaluation. I think it's unethical ultimately to do so, because there's a very good chance that money might be wasted on something that doesn't work. And the only way to find out whether something does or doesn't work, or the ways implemented might need tweaks, edits, or a fundamental rethink, is to have evaluation data. So if you think about good old practice, so in implementation practice, not even trial, we're not even in a trial or study research kind of context. If you look at implementation textbooks, they would tell you that any implementation effort, like the actual act of implementing, has to have implementation monitoring as part of it, which Ioannis was referring to earlier as a data infrastructure. We need to be able to create a mechanism to know what the implementation looks like, who we're reaching, who we're not reaching, what they're doing with the stuff that we're providing, and so on. So I think there's an absolute minimum effort, if not least for quality assurance for how an intervention or a program is being rolled out, there needs to be reflected on any budget, unless there's something that can be done really quickly, small programs, that small level of improvement aimed at, and so on. But if you look at any budget, in my opinion, that's got 6 figures to it, I think, and my experience of funders who fund this kind of work, anything between 20 and 40% of the budget needs to be allocated to evaluation activity. So it's not an afterthought. Evaluation is not the cherry on the cake, is a layer of the cake. There is no point of running a new service unless you're going to collect some data as to what the service is achieving, because otherwise you're never going to know, should we put it through a trial? Should we sustain it without a trial? Should we not? We're flying blind. So in the same way as we don't do that in other parts of our lives and don't expect to be subjected to it, I don't think we should be exposing patients or residents or populations to unevaluable or non-evaluated interventions. So it's not a nice to have. It's, I think, an absolute necessity. And therefore, we might shorten or lessen other aspects of what we might be able to implement for the sake of doing a reasonable yet rapid evaluation to then inform subsequent decision making. So that would be my take on this question.
Thank you, Nick. So we really have just a few minutes left, and a few people have asked, how do I learn more about this subject? Well, we already mentioned that there is an upcoming course by Professor Ioannis, which I strongly encourage you to enroll, where you will learn this subject much more in details, of course, of what is possible to do in 1 hour. I will also encourage you to keep track of all the activities that BISI offers. We have a range of activities that we do, and I think they are all somehow related to the issue of evaluation, of course, with implementation science and also behavioral science. I want to thank Ioannis for the nice presentation and the clarity of exposure of fairly complex concept that is not easy to summarize in a short time and quickly. I would also say that I think as my role as moderator, obviously, I'm not really adding anything else, but I strongly agree on the fact that as many people used to care about things like data protection and privacy, and they started to talk about privacy by design, I think we should talk about evaluation by design in many policies, because it's no brainer to me that there is nothing more costly than a policy that is designed and fails because you are not able to evaluate its performance. So everything that might cost the evaluation is still a saving compared to a bad policy run with no effect. So this is typically what I try to argue to policymakers, and generally they agree on this point. Okay, so I will also want to reassure that for the questions that we were not able to answer live, we will provide a short answer afterwards by email. Thank you for all your questions. I could only select a few of those. And I think we are pretty much on time. So thank you all for participating. Thank you, Professor Ioannis. Thank you, Nick. And have a good rest of the day.